Good morning, everyone. I'm Dr. Nilesh Kumar, and I'm going to present Botropase optimized conjunctival tissue grafting, that is BOT graft, a series of 52 primary pterygium. So there is no financial disclosure related to this study. So pterygium is defined classically as triangular fibrovascular growth of conjunctiva extended into cornea, and a meta-analysis shows that the incidence can range from 0.07 to 53% depending on where the patient is located, near to the equator or not, and it gives foreign body sensation, burning, watering, blurred vision, poor cosmesis, and everything. So the current treatment challenges is that the conjunctival autograft, which is gold standard, is fixed by either sutures, fibrin glue, or autologous blood. The autologous blood is the most cost effective right now, but there is a very high chance of retraction, hemorrhage, and as well as graft displacement. So there is an unmet need of cost effective, safe, and efficient graft fixation method. So here comes Botropase. Botropase is an old drug, hemocoagulase enzyme that is derived from Bothrops jacra snake venom, and it is commercially available as 0.2 Cu and 1 Cu, and it costs around 180 per bottle. After that, the study is aimed to evaluate the safety, efficacy, and cost effectiveness of the same drug in primary nasal pterygium surgery, and the secondary outcome was to assess the graft stability, adherence, and the surgical time efficiency. And it was compared right now with the available literature. So it was a retrospective case series with a 10-month plus follow-up period in a secondary ophthalmic center with a sample size of 52 grade 2 primary nasal pterygium. All the ethical committee clearance was taken, and the recurrent pterygia, double-headed pterygia, bleeding disorder, previous ocular surgery, and the patients who were unable to follow up were excluded from the study. All the patients were operated under peribulbar block and akinesia, and the standard preparation was done. And this is the surgical technique that was there. So a subconjunctival extensive dissection was done of the pterygia tissue, and the head was removed by pterygiorhexis by avulsion method, and then the cornea was cleaned with a crescent blade and burr wherever it was required. And one drop of Botropase, it is 0.2 Cu preparation. It was done so that the the bare area sclera is reduced, and the size of the graft required is reduced. It also gives hemostasis at that time, so you don't need to use any cautery. And then you raise the graft as done, and I just do a sublimbal dissection so that I get a little bit of limbal stem cells in the raised graft. So it is now rotated and kept in place. And once it is ironed out, we need to make sure that there is little bit of ooze. You can see there are little pinpoint ooze that are there, and on that the Botropase works and gives you the adhesion. So after that, a little bit of dabbing was done, and the excess fluid was done, and then again what I do is raise it, and when I am going to raise it, you see already it is real-time surgery, and you can see already the fibrin strand that have formed. So it is that fast, and it gives quite a good amount of adherence. And I just put one extra drop of Botropase, again wait for 1 to 2 minutes, and then close the case. So the post-operative protocol was that I was padded for 24 hours, and the dexamethasone for 8 times tapered weekly with moxifloxacin, sodium hyaluronate, and vitamin C was done. And the patients were followed up at day 1 week, 1 month, 3 months, 6 months, and then the last follow-up whenever they came. So this is the index case, and you can see at 1 week post-op, the graft is well adhered, centered, and the clarity that it gives. So the total surgical time came down to 18.3 minutes, including the wait time for adhesion. Compared to fibrin glue, it took 23.2 minutes because the fibrin glue needs to be prepared at that time. Sutures took 35.8 minutes, and autologous blood usually takes around 25.6 minutes. So it's significantly faster. 98%, like 51 out of 52 cases were actually adhered, didn't move. One had minor displacement, came towards the limbal side, but it was not very significant. No retraction, no graft loss, and no recurrence noted, no granulation. One case had a minor granulation tissue, but resolved with topical steroid, and no allergic reaction. Now coming to cost effective, it is 180 rupees, and I use it only for one case. You can use it for multiple cases. Fibrin glue cost you around from 3,000 to 17,000 depending on how many cases you fractionate it to, and sutures cost you around 800 rupees. So it's very cost effective, improved outcome, and faster surgery. gives a perfect cosmesis because there is wound healing capability also. As you can see, what it does is it gives factor 10 activation.
So you're out of time, Nilesh.
Okay, ma'am. So I'll just.
You cannot just.
Yes,
We'll go on to the questions.
Yeah.
So Nilesh, excellent paper, and I'm glad that you were able to present very comprehensively. I know you don't have financial interest, you said that in the beginning. So exactly which company, in case anybody wants to try? So which?
It is available with this, I just forgot. It comes as the name of Botroclot, and it is available from a pharmacy. It is in South, based in Bangalore.
All right.
So
maybe others can get in touch with you at the end of this, after the session. So the one sort of confounder that I can see in your entire paper is that you are using Botropase, but you're also waiting for the blood to clot or to ooze. So how is it not a combined mechanism that you both self?
It requires a little bit of, because the drug is not having fibrin in itself. So we need little bit of fibrin, but compared to the amount of blood that is needed for autologous autologous technique, this technique is having little bit, the ooze needs to be quite less. So the cosmesis increases, and I have done a separate study that is submitted in AIOC. So it compares actually with Botropase and only autologous blood with fibrin and sutures as well. So there are 4 arms in that study. So my question to you is that what is the advantage of, you mentioned one advantage that you don't have to wait. So you have a few saving of a few minutes. And
over blood.
And wound healing is better, ma'am. So within a week, you can't see the demarcation line between the graft tissue and the host tissue. And till 10-month follow-up, the cosmesis was really good. So that is additional advantage over autologous blood.
What's the duration of follow-up in your study?
Till 10 months I have done right now for this paper, but now I have a follow-up around 18 months totally. And I just remembered the name, it's Jagat Pharma.
Did you look for any graft shrinkage or graft attachments?
Yes, ma'am. No retraction.
What is the percentage of that?
Yes, ma'am. No retraction was noted. Only one minimal limber override was noted.
And any increase in amount of scarring or fibrosis at the grafters?
No, ma'am. What it does is the wound healing, the fibroblast migration happens. That is the mechanism of action.
Did you note in the cases I meant to ask, in your methodology, did you keep a column for these?
Yes, ma'am. I have mentioned, ma'am. It was not there. Thank you.
I just wanted to mention that forget sutures. I don't think anyone wants to take sutures. And the only problem with fibrin glue, most of us have excellent results, but of course it's a cost.
Yes,
and also if you're aliquoting, you can't aliquot it really, but when you use it for multiple cases, then there's always chance of contamination and infection.
So a 12-center multicentric trial is on, ma'am, for this comparison of fibrin glue versus Botropase, ma'am.
Thank you. Excellent. Thank you.